Hi, everybody, and welcome to EndoCast. I'm your host, Leslie Bishop, and this is episode 33 with our physician guest, Dr. John Tann of HCA Midwest Health. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you. Dr. Tann, welcome to EndoCast.
Thank you for having me. I appreciate it.
Yeah, so I'm super excited to hear about your bariatric practice. Before I get started, will you just give me an introduction? Where are you from? Where's your facility? Tell me about your practice.
Yeah, so I'm based out of Kansas City. We operate on both sides of the state line. It's one of those split cities across both sides. And I do bariatrics. I also do foregut, so the hiatal hernias, reflux. And there's a big overlap with bariatrics. And then we do a lot of advanced endoscopy. So we'll do a lot of the scoping, or where people put the cameras down the mouths, not just surgery. So a lot of times we combine those as well. So I've been doing that for about 6 years out of Kansas City, and building that practice, developing that community, and really, being able to see a good impact. So
tell me why you decided to incorporate endobariatrics into your bariatric practice.
It's been a natural thing since I was a trainee, and I got lucky, basically, in a place where I had some very influential mentors who were already involved with endoscopic care and were doing it. And so I've been involved in the training and or application in my own practice now since 2016.
Of endoscopy?
Mm-hmm.
Oh.
Well, specifically with regard to bariatrics.
Oh, interesting. Okay.
So endoscopy, I've always done endoscopy just because surgeons do get training in that from day one. But I really leaned into it pretty heavily and went through some advanced training as a resident even before I graduated, because I knew I wanted to make it part of my practice.
So when you're thinking about all these patients that you've treated, what's different being able to offer the endoscopic option?
Well, there's definitely a fair number of people who shouldn't necessarily have an operation or who don't want to have a surgical operation for a variety of reasons, either from a risk standpoint or just from, their own personal, they just don't want surgery. And when you look at disease severity, and we're treating a disease, obesity is a symptom or a side effect of a metabolic problem that's genetic in nature, and not everybody is going to have the same treatment because they don't have the same severity of the disease. So if you have someone with high blood pressure in the office, and a primary care doctor is going to tell them to have diet, lifestyle modifications, cut salt out of their diet, etc., and then see how that goes. And then next level is a medication, next level is a couple medication, and eventually there's surgical indications and cures or treatments for hypertension, depending on what is causing it. So when we look at obesity, there's different levels of obesity and different levels of metabolic disease with different side effects, different comorbid conditions. And so if we have endobariatric options where we can treat people without surgery at those different levels of disease, that's a really great option to have. And so it's just another thing in the armament of tools that I have to treat patients.
So talk to me about how that conversation would go with a patient.
Well, so when we are discussing their options, it's important to first understand the disease. And I start everyone off kind of in a similar way, explaining their disease to them, and that it's a disease, not a choice, because they've been told their whole life that it's a choice, and that they're fat and they're lazy and they've made bad choices in their life, and that's why they have this problem. So getting past that hurdle and really truly understanding what we're treating. And then once we figure out what that treatment is or what we're treating, then we can talk about the options. And so then, depending on the severity of their disease and their different problems that they have, comorbid conditions, reflux, et cetera, hiatal hernias, et cetera, then we can look at the different options, whether that's, endoscopic versus surgical. And then I just discuss everything with everybody, from medication to diet, lifestyle modifications, endoscopic options, and surgical options. I just discuss all of them because I do all of them and offer everything.
I'm curious, it doesn't sound like you did, but did you have any hesitations offering the endoscopic option? Because I know sometimes that can be a hesitation for surgeons. Did you have any hesitations to that?
No, actually, for when I first started in practice, I think I was doing more ESGs than anyone else in the city was.
Oh, interesting.
Just from the start, and which is partly because when you're ramping up a practice, it takes a while to get busier just because there's an insurance lag when it comes to working people through the program. And cash pay is not, there's not a lag. And so being able to just like lean into it pretty heavily is pretty, it's not that hard to do. And I had done them in training.
Okay, speaking of cash pay, what do you think about the CPT code coming out?
Oh, it's going to be really great. I mean, all codes, there's a lot of very complex things when it comes to billing and coding, and I'm very involved in that and do stuff with our national societies in insurance, and I've learned a lot. But I think overall having a CPT code for that is going to be just revolutionary.
Yeah, it's exciting for you guys.
Yeah.
So I'm curious how your peers responded, your bariatric surgeon peers. How did they respond to you doing endobariatrics? Has there been resistance?
All three of my partners, so there's four of us. Well, there was four, now there's two, but all four of us do endobariatrics in some fashion. So it's been very easy from my practice specifically.
Is that the case nationwide?
Oh, no. I think I know personally like just a couple other people that do any endobariatrics that are bariatric surgeons. It's not popular.
What's the resistance?
Well, I think when you look at it takes longer and it's harder to do. A lot of times it requires a lot of marketing. It requires a lot of overhead in terms of training for your staff. And when I say overhead, I don't necessarily mean like a brick and mortar. I just mean it takes a lot of extra effort in your staff's education, how to take care of patients, the post-care, the preoperative learning for the patients. And so then your staff has to know and be comfortable with all of those things. You have to be comfortable and know all those things, which is why I think it's easier for a surgical practice to get into that versus just a straight GI practice, because we're dealing with the disease already. And so it's easier to target those patients, and it's easier to provide them the education that they need. You have to get bought in.
Yeah. So what do you think those bariatric surgeons need to know? What is it that they don't know about the endoscopic weight loss option that if they did know, they would want to incorporate into their practice?
I think one of the bigger barriers is that it works. And
that's a barrier?
Yeah, that's a barrier.
And I don't understand. Why is that a barrier?
Well, because a lot of people don't think that it does.
Oh.
Yeah. And, there's data to prove everything on every side of the equation, right? We live in a society where there's really intelligent people on very polar opposites of a lot of issues.
Oh, yes.
And so I think from a point of intelligence, the best thing to do is to step back, see that, and realize that the solution's in the middle. And so when we look at something like endobariatrics versus surgery, especially for surgical practice, I think the philosophy for both bariatrics and foregut for me is offer everything and to at least have the knowledge. There's a couple of things I do from a foregut perspective. I do 1 or 2 a year, right? But I'm also one of the only people that do them, but that's not for every patient. But at least we offer it so we have the ability to have an intellectual conversation with the patient about their options in a real way. Not just, oh yeah, this exists and I don't know about it and that's why I don't like it and why we're not going to do it for you. But if you say, yeah, this is really what I want, I'm like, yeah, you are a candidate for it, so then we could do this. Bariatrics is the same way. If you don't offer everything in your bariatric practice, are you really a bariatric practice? No, you're not.
I'm sure all the bariatric surgeons listening love hearing that.
We all have a great time together. No, it's a fun time.
All right, so thinking about patients, what do you wish more patients knew about the endoscopic weight loss options?
From the perspective of the patient, I think just knowing that it exists is probably the biggest barrier, and knowing that it works in a way that isn't just, oh, here's this thing that I see on this marketing, does it really work, and how does it work the best, and how do I know who to get it done by? Because there's a lot of variability to it. It's a very manual thing where you see like each specific physician or the person doing the procedure may have a different philosophy behind it, but that's the same way it is for every procedure that we do. Every sleeve's different. Every bypass, every SATI, every mini bypass, they're all different. And everybody was trained a little bit differently. So just really, the thing I always tell patients is like, you got to have good vibes, like with your surgeon. And if you don't, then go see someone else. And if that's not me, like if you don't feel good about this, then I have other people you can see, like just get treatment. And so when it comes to the options for endobariatrics, having an ESG or an endoscopic sleeve gastroplasty or a gastric balloon, there's reasons why they work and why they work in a physiologic way, not just keeping people from eating, because that's not why people lose weight, is not eating. That's a diet, and we know diets don't work, because it always comes down to the patient. And that's why I personally, no offense to anybody else, but that's why I personally try to offer every single procedure to the best of my ability, because then we can actually say, all right, as a patient, here's your risks and benefits for these different procedures. I would tell you from my professional opinion that these ones are in the list of ones that we should or could do for you. And then let's discuss specifically you and what you want for the rest of your life. And so then if it's in there, the sleeve, the VSG or the vertical sleeve gastrectomy, I do that the least amount of all the things that I do.
Oh, okay.
Right. And from a surgical perspective, just because I don't like cutting the stomach out. Like, it seems important. And it's the most highly revised surgery for a variety of reasons.
What are the reasons it's the most highly revised?
Mostly reflux.
Okay.
And a lot of times that's because a lot of people just do sleeves. They don't do anything else. So they don't ask patients about reflux. And so there's a lot of patients that have reflux, and reflux to the point where they're getting esophagitis or Barrett's, or they're hurting the lining of their esophagus, which can lead to cancer. Or, they, have weight gain. And a lot of times the sleeves are just too big. That's another super unpopular opinion, is sleeves don't dilate and pouches don't dilate. They're made the size they're made.
All right. I love hearing patient stories. So do you have a patient story or two that just a life-changing story about someone who got an ESG procedure?
Oh, yeah. A lot of people do really well if it's a mother-daughter combos, and it's really fun to see.
Mother-daughter combos?
Oh, yeah. There's a lot of family combos in my practice.
Come on.
So
that's so fun.
And, I think this particular mother-daughter, they didn't look that different. I mean, they kind of seemed like the same person. They looked like they're the same age, too. And so there was a great competition between the two of them. I have a couple mother-daughter combos, but the competition is always very helpful when it comes to their outcomes, because it keeps them on track a little bit better. And they did their follow-ups and came back in, and it was a heated competition. The mom ended up winning.
Seriously?
Oh yeah, she ended up winning. But they both started off at a BMI of about 30. I think they were right around 35 plus or minus for both of them, and then ended up at a BMI of 20, almost all the way down to 25. I think the daughter ended up just slightly above that, but the mom got all the way down to a BMI of 25 within the first year.
And how long have they kept that? How long ago were they?
Oh, that was probably about 3 years ago. So yeah, still doing really great, keeping everything off. So.
That's awesome.
Oh, yeah. And a lot of times, because these are cash pay, a lot of times now, before we get the CPT code, that it's going to really push the payers into covering this. I've had a few covered, but for the most part, the reason people are comfortable doing that is because they've been cash paying for failure, but it's not true failure because you're not doing anything that really is going to be proven to work. It's like if you have cancer and you cash pay and you're trying to take tomato juice and you're eating some sort of salt diet, or you've just whatever the remedy is, it's not going to work until you just physically remove the disease. And it's similar with bariatrics, where you can cash pay for all the diets and exercise and lifestyle modifications that you want, but that's not how it goes away. It's an important tool to add to it. It's just like all of us should be doing a better job with diet, exercise, and lifestyle modifications. And I tell patients, your job is to have the same requirements that I do. If it comes out of a box or a window, probably not good. Liquid calories are not something that anybody should consume outside of rarity or special occasions. And then, you really want to make sure that it's a whole food, or that it's, it grows or walks on the earth. And that's probably where you should go, and then try it out and see how it works for you. The complicated books of what you should eat and what you shouldn't eat, what you could drink, what you shouldn't drink, and don't do this and don't do that. There's so many rules that people can follow. I'm just step back and just say, I'm going to make this a little bit more simple. Sometimes it takes rules to get there, right? We need the structure ahead of time, but then things become much more relaxed. And when they get 2-3 years out, they have a pretty normal diet.
Basically, you want them on the outside of the grocery store.
Yes. Oh, yeah.
That would help Americans a lot if they just stayed on the outside.
Yes.
Of the grocery store.
But even there, I mean, honestly, like it's not the what's best is not feasible because of the way our society has become. The best thing is to stay out of the grocery store and go to the farmer's market, right?
Oh.
Like, but how often am I at a farmer's market? Not enough. Like hardly ever. It's a goal. It's a goal in life.
Yeah. All right. Talk to me about your discussions with patients, talking about all the whole spectrum from medication, diet and exercise, endoscopic options to surgery. What does that conversation look like?
I make them say, I'm like, why are you here today? And that's a fun conversation because it's like, well, who's making you be here today, right? Who forced you to come in? Or are you here on your own? And then, they'll usually say something, oh, I want to lose weight or whatever. And I'm like, okay, that's good. Like, you're in the right spot. Like, we are now identified that we are both here for the same reason. So do you know why you have the extra weight? And, sometimes I can gauge if I even need that question, or if it's like, oh, we're not going to have a back and forth today. I'm just going to tell you.
Sometimes they just stare at you.
Mm-hmm. Yeah, no. Or they just look at the person in the room and they're like, So then I go through the whole metabolic disease, and then I point out to them their severity level based, there's questions I ask them and other surgeries, right? So like not only what surgeries are better for you just from like if you're this perfect, specimen that we don't have to worry about, but then sometimes people have had other surgeries that change what we would want to do. And then we have to make compromises because it's all a category analysis of risk benefits. And then what options do we have? And then where are we going to give a little and take a little? So then once we go through medications, why, most of them have been on the medications.
They have. When they come to you, most of them have?
Oh, yeah.
Interesting.
I mean, there's a whole separate talk. It was like, what are the medicines? What do we like about them? What do we do not like about them, et cetera. But I would tell you most of my patients have been on the medicine. Specifically now, the majority of that's going to be any of the GLP-1s, like Ozempic, Wegovy, Mounjaro, et cetera.
Okay, so that's very interesting. So why are did they stop the medicines because they were having side effects?
No, most people don't lose weight from them. A lot of people do. I mean, there's remember, a great result is going to be something like 30 to 40 pounds. That's amazing. And so to have that great result, you only need to lose 30 to 40 pounds. Like that's all you need to lose. There are definitely people out there, and you'll see them online, et cetera, that have lost 100 pounds. But just like if you have high blood pressure and you're taking a medication for high blood pressure, if you stop taking it, your high blood pressure is going to come back unless you fix the problem. And when we look at what obesity is a side effect of a disease, when they stop taking it, I mean, there's some people on social media that get really hot and heavy about how they haven't lost any muscle. Well, they have. Like, it's obvious. It's just what the data shows. I mean, that's all we should be able to do is just look at the data and say, this is what it shows. And sure, there's people who have results from things, but there's also people that get cured of disease. And there's people who get cured of cancer and heart disease that we have no explanation for, who didn't have to go through surgery. We don't have an explanation for it, and that's okay. It's okay. And so there's people who lose weight and have, from genetically speaking, who have a metabolic disease who can make diet lifestyle modifications and can lose a lot of weight. That's not most people. But then they get online or they get highlighted as, well, I did this, so you can too. No. I mean, that's just a disservice, and shame on them for making all the rest of the people who have extra weight feel personally responsible for that. Because the majority of my patients have made the lifestyle modifications, have made the diet changes, are exercising more than everyone else they know, eating less, sitting at a table of their peers, weighing 200 more pounds, 100 more pounds, and just have been dying their entire life, restricting themselves their entire life, and then never see a result. Yeah, I'd feel like a failure too.
Yeah.
And then you give up, and then you see someone eating at a restaurant. I mean, I'd talk about weight bias or bias in healthcare, and I'll be the first to say sat in many restaurants growing up before I understood any of this, and I would look at someone who was fat and I'd be like, oh, just stop eating that, and then you wouldn't be so fat. Like that's how America thinks. I've had this conversation with a bunch of people, and I will have this conversation in a very public setting if they want, and I will just call them out on how I think it's ignorant, because I was there. And I think we should call out the ignorance. It's okay.
All right, so I diverted you from the question because I want you to finish. You were talking about, because I wanted to know about the GLP-1 thing. Yeah. But I was asking you about your conversations with the patients. Right. So because you were on a roll, and I want to hear. I want you to finish on that.
So we'll talk about the medications and what role they play. Either before or after. A lot of them have been on them or are on them and haven't lost any weight. But a lot of times they're also on them for diabetes, which is their intended purpose.
Right.
These are diabetic medications that have a side effect of weight loss in a few people. They also have a lot of other side effects. So then we talk about that, and then we talk about the different endoscopic options, so balloons and ESGs. And then we'll talk about surgery, and that usually comes down to VSG, or the vertical sleeve gastrectomies, the gastric bypass, or the Roux-en-Y gastric bypass, the mini gastric bypass, or the OAGB, the one anastomosis gastric bypass, and the duodenal switch, and then of that, the SADI version, which is the single anastomosis duodenal
Do you have a chart when you're discussing all these things?
No, but it just gets said every time. So it just rolls. And then I'll draw all of them on the screen for them, because it gets very overwhelming.
Yes.
And so I spend the majority of the time at this smart board, and I will draw, and I have a certain color for every single one. And I have my own thing. Like, it's very regimented. It doesn't vary very much. And then I'll throw something, every now and then I throw something new in, and it's like, oh yeah, that was kind of cool. And we'll see how that goes, if it gets part of the routine or not. But I have to be careful, because I'll end up talking way too fast and just like blowing through things. But you got to kind of gauge if the patient's into it or not. But I find it very helpful to draw everything for them. Like, physically draw what the balloon looks like, where it's at in the stomach. It's got this big anatomy thing up there. They can see the esophagus coming down the stomach. They can see all the small bowel, the large bowel. And then I show them how the metabolism works, how the food transit works, and then how each one of them, by showing them what physically it looks like on the screen, and then what we're doing to change it, and then how that change takes an effect on everything else. And it helps, I think, significantly for them to see a rough drawing of what we're physically doing, because otherwise no one ever explains any of this to them. And half the people that I see that I'm doing revisions on that had surgery somewhere else and have some issue that we're changing, and it's okay to have revisions, just like it's okay to get more than one heart stent or more than one surgery for everything else. Since we're just treating disease, it's okay to have revisions. It's not because they failed or did something wrong. But when we're talking about what we're doing, most people don't know what we did.
They don't know what surgery they had?
No, they may know what surgery they have, but they don't really understand what we're doing.
They don't really understand what. I get it. They don't understand why, but they don't understand specifically what was rerouted or what was changed in their body.
Well, no, because you think about the general knowledge of what people have about what their body looks like to start.
Yeah, but if you're getting surgery?
No.
No? Okay.
No. No. Most people don't go into that. Okay. Most people don't want to know.
Oh, interesting.
Right? It's, like the thought of blood or the thought of surgery, so they don't want to look at that stuff.
They're like, just fix me, doctor. Whatever you do is fine. Okay.
Correct.
Yeah.
And for the most part, when we're doing laparoscopic surgery, or we're doing minimally invasive surgery, or we're doing endoluminal surgery, there's very minimal incisions and they all look the same.
Oh, okay.
Right? So from the outside, you've just got a couple cuts, or you have no cuts if we do it, endoscopically.
So after your conversation with them, do they usually know right then, I want this thing, or do they have to think about it? What's the response for most of the patients?
A lot of patients come in kind of already having done some research and know people, or have an idea as to what they're thinking. And I would say the majority of patients end up picking something different.
Really?
Mm-hmm. Because they're not familiar with all the options. They're familiar with like one or two. And they don't know that really it's closer to 6 or 7.
And they usually pick something different.
Mm-hmm. Because they may have a side effect or a comorbid condition that they're not familiar with and how that relates to it. So when we, if someone has diabetes and reflux and they're medicated for both of those things, and they have a BMI of, let's say they have a BMI of 50, they have diabetes and on insulin and have reflux and take a proton pump inhibitor, like omeprazole, Nexium, whatever. They come in and like, well, I want a sleeve because my dad had a sleeve. Well, a sleeve's probably going to make your reflux worse and probably won't help with your diabetes. You'll probably still be taking insulin, and your BMI is 50, which means you probably won't lose all the weight you want. I'm like, what do you mean? I'm like, yeah, that's just what the numbers show. So then a gastric bypass or a mini gastric bypass would be a better option because A, we're taking care of the reflux, and we don't have to worry about, esophageal cancer down the road, and it helps with your diabetes, and it gets more weight off. I'm like, oh, so we can do one thing and it cures 3 problems or fixes or helps. It doesn't cure. We don't cure disease.
Okay, that's very fascinating to me. So I want to think about the future. I'm just curious your vision of how this endoscopic weight loss thing is going to go. How do you see that?
I think it opens up a lot of doors. I think with endoscopic options, again, it's helping bridge the gap. And there's a lot of people in the gap, where we say, well, I mean, it's here, the gap people are the hardest people to treat because a lot of times they haven't qualified for payment, but they're also still in a disease state. All right. So the CPT codes, the future of that coming out, payers getting more, but it's also some good procedures that are helping people that have those lower BMIs. Whereas with surgery, a lot of those patients are going to be a lot bigger because we need a higher treatment. We have more severe disease. We need a more aggressive treatment. But when you have people inside that BMI range, when we're looking at the different types of people and the BMIs that they have, from a surgical perspective, just from our guidelines, we're not really looking at treating anyone with a BMI less than 30. But there's going to be, the normal BMI is 25. And so to put that into different perspectives, you have to really look at the body makeup. And so depending on nationality, body type, a BMI of 28 could need treatment. But sometimes a BMI of 28 isn't. Like I have a BMI of 28, right? So, but
No, you do not.
I do, but it's because it's a weight height problem, right? So it's just based on weight and height. I have dense.
You got big muscles.
Dense. Dense. I hide it. But there's a density problem, right? So like for me to be a BMI of 25, I would have to lose 30 pounds.
You would like disappear.
Correct. Right. And that's not so, but different people are shaped and built differently. So we have to look at each specific patient. And so a BMI of 28 or 29, I'm not doing surgery. Right. So, but there's a really great option for patients with these endoscopic options. Really opens up some doors for patients that either shouldn't get surgery, don't want to get surgery, or it's just a good option for them when it comes to what can we choose.
All right. You mentioned that there's a lot of resistance with bariatric surgeons in general for the endoscopic option. So if you were to speak to them, what would you say? So
it's all about the patient and making sure we have enough options because there's different patients that need different things. And it's really, taking that time to say, here, we offer these different things. These are all approved by SMBS. This is what we can offer patients. It's in our best interest as bariatric surgeons, as leaders in that disease space, to say, these are our treatment options. And I offer all of them because there's patients that should get those.
I love that. All right. So I have one last question. I would think what you do would be a very rewarding, it seems to me from my perspective, it would be a very rewarding job.
I always say that my favorite diseases are the ones that are super marginalized. So I only do bariatrics and foregut. So foregut being hiatal hernias and reflux, etc., where a lot of people don't understand them. They live with them because they're told this is just the way it is. And then there's medicines that help them, but they don't necessarily. And no one tells them that there's options. There's not treatments. And then they explain it differently, right? So from a rewarding standpoint, I think, only reason I do this is because most of the outcomes are amazing, right? And even outcomes where someone's got some chronic nausea or some dysphagia, or they can't swallow like they want to. I can't think of any patient that, when you look at a year later, 2 years later, after they've lost 150 pounds, like, I'll take the nausea all day, right? Because I can go to the amusement park. I can sit on an airplane without taking up 2 seats. I can walk without getting out of breath. I can go outside and enjoy nature. I can exercise now because I can actually move. So every day, if I ever question like my job satisfaction, I just have to go to clinic and see my 1-year follow-ups. And all of a sudden it's like, oh yeah, this is why I do this. And that's just every day in clinic.
That's amazing.
Constant reminder.
That's amazing. Dr. Tann, this has been so interesting. Thank you so much for coming on.
Thanks for having me. I really appreciate it. The conversation's great.
Thank you.
Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, EduCare. That's edukare.bostonscientific.com and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.